2 years, we are honored to be with you at the 8th May-Day event in collaboration with the Mediterranean Academy of Mastology and the Faculty of Medicine of Aristotle University of Thessaloniki. This year's theme will be Benign Breast Disease High Risk Management. The meeting will be conducted in English. We will have numerous international and Turkish speakers contributing to the discussions. Distinguished guests, welcome. Our program will continue for 2 days in 7 sessions consisting of panels, lectures, and presentations. Before we start our program, I invite you to observe a moment of silence in memory of the founder of our country, Gazi Mustafa Kemal Atatürk, and our revered masters, followed by the reading of our national anthem. Thank you. Now it's time for our university promotional film. We wish you a good viewing. so much. We would like to begin with our opening session. I would like to invite Professor Dr. Bahadır Güllüoğlu to provide information about the course introductions, objectives, and orientation.
Good morning, everyone. So this is the fresh start for the morning. We have 2 days of the course program with 7 sessions, and I would like to say welcome to all of you. And we have guests also from 8 different countries now representing their countries with formerly it's called MANOS-Med and MANOS-Medi, now it's called Mediterranean Association of Mastology. We have guests from Greece, from Cyprus, from Romania, from United Arab Emirates, from Malta, from Azerbaijan, if I'm not mistaken, and also from Albania. In fact, Helidon Nina, Professor Nina, cannot be with us. He will be giving a presentation about gynecomastia as a guest speaker, but he will be on video because he has an excuse and he cannot come, and he sent his excuses and apologize because of his absence as well. So today we have sessions in the morning and in the afternoon, and tomorrow we will be also continuing with the scientific sessions about benign breast conditions and also the high-risk management. And we believe that for the breast physicians, that is one of the important issues. Why? Because 80% of our patients or the women coming to our outpatient clinics are mostly benign conditions. So we're not in Turkey, for example, and I know that in many countries, and we have patients with the complaints of benign conditions, and we're dealing with them and also the high-risk conditions. So this meeting is not concentrated on cancer or DCIS or early or the late cancer. So it will be an important issue for us to give this 2 days of conferences and lectures about this, and we believe that we will be filling the gap in this area as well. So at the end of tomorrow, and also we have a young investigator session just in the morning, and that's also important for us because in order to encourage our young investigators to do and perform their scientific research and have the opportunity to give their presentations here in front of the audience. So that will be an encouragement for all of them. So we would like to have you here in this audience and to support them as well. So we will have 4 presentations from Malta, from Italy, from Turkey, and from Greece. So at the end of the second day, and when you look at the program, there's an exam. So it's always a frustration for people who are just attending this, meetings. But that exam is just a formality because this is a level 2 education, meaning that not only you're sitting here, if you would like to sit down for that exam, and if you pass it, you will have an achievement certificate. But otherwise, if you would like to just sit down and listen and do not enter that exam, you will have an attendance certificate. So at the end, please do not ask for an achievement. Why I don't have this achievement? Because if you're sitting in the exam and passing the exam, you will have the achievement certificate, which might be useful for future in any case, and will be signed by the rector of Kocaeli University and also the representative of the Thessaloniki University of School of Medicine, which these 2 universities are now making a cooperation together closely. So I would like to leave the floor to Professor Konstantinos Dinas. Kostas, can I have you here? I don't know if you would like to, I don't know how the, officially will be announcing the next speaker, but Kostas is a close friend of us from Thessaloniki, and we have a very close collaboration for a couple of years, and we have also future perspectives. No, you can come up here, please. You can come up here. Welcome.
Dear friends, authorities, and most of all, dear young colleagues, dear students, it's a very big honor for me and many of our team to be here with you. It is a big privilege because this is the start of a very deep scientific collaboration. As the key structure of the new Mediterranean Association of Mastology, in which I will have some words to you, we are on the process in establishing a master program a bilateral, bi-country master program between the University of Thessaloniki, the Aristoteles, and the University of Kocaeli regarding breast diseases. It will be an official master program accredited by the European Union, which will be endorsed and signed and accredited by both universities. It is not an easy task, it's a difficult task, but my dear friend Professor Senturk, dear Zafer, he's so kind and so willing to do this, so we are working together. It takes some time, but I believe within the end, until the end of this year, it will be ready. So next year we can take the first applications. Regarding the Mediterranean Association of Mastology, it is an organization which actually is new in the law, in the formality, but actually it's a very old one because it's the evolution of the old Manos Medi or Manos Medi, the Mediterranean Academy of Mastology. Things evolve, things change, people grow, become older, so I think also institutions have to adapt to the newest standards of education. Somebody could ask why another association, why another academic formality. The only thing actually from our point of view in which this association exists is to give the younger generation the boost they need to evolve further. There are so many associations, everybody of us has been or is or will be president of so many academic societies, national, international. It is not something which we do for ourselves. I think with the help of God we've done much more than we expected when we started studying medicine. I'm born in 67, so I'm now 58. So I think what is done is done. So the only thing which is very important for me, not only as a physician, I'm a gynecologist, but also as an academic, is to give the opportunity to the younger generation to become better than us. There is always in Greece and the European Union saying that the younger generation is not willing to work, they don't want to do anything, they are used in luxury. It's not reality. There are so many young people who want to evolve, who leave their houses, their nice way of living, and they go abroad just to further their perspectives and to become better. So actually this is the main reason why this new association was born, to give the younger ones the skills and the help they need to fly further, to fly higher, and to be much more successful than we were. It is an association in which actually all the countries which have to do with the Mediterranean are welcome. But you know, everybody in the end in this world has to do something with the Mediterranean, because water does not know any borders, and even a small river who starts maybe in Siberia or in Africa, in the end of the day, some cells from this water will come to the Mediterranean. So actually it is a society which needs to have a water, but in the end of the day it's something in which we would like to grow further and further, having as a start the Mediterranean area, in which there is a long history, a long tradition of cultural intervention, of people intervention. All the people who live in this area have much more in common than differences. So I think this is also a good start to further expand the collaboration, not only between persons, but also between countries and institutions. So I believe this afternoon we have the first official executive meeting. There has been a lot of work done before regarding to issue an establishment so that we have a signature, we have a stamp, we are a company with a real name, as all the companies have to be. and it was a big help from all the previous members who were members in the past of Manos Medi. It is a great pity that because of the now political situation, the president of the Mediterranean Association cannot be with us. Nezib Kiakan, he is a professor of surgery in Lebanon, but due to the alleged circumstances, he cannot join this Congress, but I'm sure that he would like so much to be here as we all are. I represent his presence here as a secretary, and I believe that in the near future, most of you will hear a lot about this the new association. Our site is under construction at the moment. We are also producing the final steps in which we will all evolve. We will talk this afternoon. And I once would like to thank Professor Senturk for his kind invitation, for this very nice idea he had, he and Professor Guloglu, to organize such a meeting about benign breast conditions or diseases, or you can call it as you like, because in the end of the day, we all would like to ask with benign cases and with malignant, although malignancy is the core aspect of our specialty. So, in the name of the Aristoteles University of Thessaloniki, the second department of obstetrics and gynecology in which I am head, I salute you, and I hope that this will be a very congress with a very big success. Thank you so much.
Thank you, Professor. I would like to invite our rector, Professor Dr. Nuh Zafer Jantürk, to give his opening speeches regarding the collaboration between Kocaeli University and Senatürk.
Distinguished colleagues, esteemed guests, dear friends, I am sorry my voice is not good, but unfortunately, I will use this bad voice to address you. It is great honor and pleasure to welcome you all to the 8th May-Day meeting. On behalf of Kocaeli University, I extend my sincere greetings to your valuable national and international participants who have gathered here today in the spirit of science, friendship, and collaboration. We, as breast surgeons in Turkey, started this journey at the beginning of 2005 with the foundation of Turkish Federation of Breast Societies. Kocaeli Breast Society was the 5th breast society, which is founded in 2005 and participated in the federation. And then 2010, we founded MyMed, which is a regional monthly meeting for Anatolian side of Istanbul and Kocaeli, with support of the Kocaeli Breast Society. Until today, we organize almost 100 meetings. Also, we founded Senatürk in 2011. Senatürk organized many international and national meetings and workshops for training Turkish and international surgeons. One of these meetings is the May-Day. This is the 80th one of this meeting. I am very proud of these organizations, these meetings to be withheld. Scientific meetings are not merely platform for sharing knowledge. They are also bridges connecting cultures, experiences, and people. Today's gathering carries a particularly meaningful dimension because it reflects the long-standing friendship and academic cooperation between Turkey and Balkan and Aegean countries. Throughout history, the Balkans and the Anatolia have shared the common traditions, cultural values, and human connections that transcend borders. In medicine, this friendship becomes even more powerful as physicians and scientists unite around the universal purpose, improving human health and quality of life. This year's focus on benign breast disease is both timely and important. Although benign breast disorders are non-malignant, they constitute one of the most common reasons for referral to breast clinics worldwide. Millions of women experience anxiety, uncertainty, and fear when confronted with breast symptoms. Therefore, our responsibility extends beyond the diagnosis and treatment. We must also provide reassurance, education, and compassionate care. The field of benign breast disease management has evolved remarkably in recent years. Advances in breast imaging, minimally invasive biopsy techniques, risk stratification, and multidisciplinary care have significantly improved diagnostic accuracy while reducing unnecessary surgical interventions. At the same time, growing awareness of the personalized medicine reminds us that every patient must be evaluated not only radiologically and pathologically, but also psychologically and socially. As breast surgeons and clinicians, we know that benign breast disease are not always simple conditions. Some lesions may mimic malignancy, while others may carry varying degrees of future cancer risk. This makes scientific dialogue and international collaboration critically important. Meetings like these allow us to exchange experiences, discuss the controversial topics, and develop common perspectives that ultimately benefit our patients. I would also like to emphasize the role of Kocaeli University in advancing medical science and international cooperation. Located at the heart of one of the Turkey's strongest industrial and academic regions, our university continues to expand its global vision through research, innovation, and interdisciplinary collaboration. As you have seen the film about the Kocaeli University, we have 16,000 students, including 2,000 foreign students. We have 19 faculty, 15 vocational schools, one conservatory, many research centers, technoparks, science parks. We try to make a contribution to global science. Also, we have 1,000-bed hospitals, and we are training our students for healthcare of the Turkish peoples. In healthcare science, and particularly in surgical disciplines, we strive to combine scientific excellence with human-centered care. We are proud to host distinguished scientists and clinicians from different Balkan countries, and beyond your participation strengthens not only academic productivity, but also the bonds of regional solidarity and friendship. Science flourishes best where there is openness, mutual respect, and shared vision. In an era marked by rapid technological transformation, artificial intelligence, digital medicine, and precision health approaches are reshaping clinical practice. Yet, despite all technological progress, the essence of medicine remains unchanged. Listening to patients, understanding their concerns, and approaching them with empathy and wisdom. I sincerely hope that this meeting will inspire new collaborations, productive discussion, and lasting friendship. via this kind of meeting, I would like to tell to enlarge our network around the world from Siberia to Far East and the West with colleagues around the globe, with Turkish colleagues together. So I am very pleased to host colleagues from Balkan region, and we will make a collaboration for mastership program together in coming year. And I am very proud of it, but I am working on it. I hope so we will enlarge it to whole Europe, maybe as Kostas mentioned, to around globe. May the knowledge shared here contribute to better patient care, stronger scientific partnerships, and a brighter future for our region. I also want to announce this meeting is broadcasting via YouTube in live, so many colleagues around the globe can watch this meeting with us. Thank you for valuable participation and presentations. I wish you all a successful and inspiring meeting and well journey. I sincerely greeting all of you.
Thank you, dear Director. I would like to invite dear speakers for first panel.
Welcome. In this session, we have a 4 speaker and 5 speech. First of all, from Medipol University, Dr. Sina Ferahman will speak about moderate risk lesions. Please.
Thank you. It's a big honor to be here. Before I starting, I would like to thank our rector, Professor Can Türk, Professor Güllüoğlu, and Professor Gençal. And I would also like to thank you, all of you. I hope we will have a productive and enjoyable 2 days course. Today, I try to talk about moderate risk lesions. Moderate risk lesions are a gray zone group. They are not clearly malignant, but they cannot be safely to ignore them. Is it a really surgical issue? I'm sorry. Now it's a little bit old school. Today, moderate risk lesions are a multidisciplinary issue. These lesions should be evaluated in 2 separated groups. One, upgrade risk factors. The other risk is long-term breast cancer risk. Upgrade means that a lesion diagnosed a benign or borderline on biopsy is found to be disease or invasive cancer after excision. For these lesions, the upgrade risk mainly driven 5 factors: atypia, radiological pathological discordance, insufficient sampling, larger lesion size, and persistent clinical or imaging suspicions. About long-term breast cancer, the key point is the lesion is pure or associated with atypia. Pure lesions usually do not create a major independent risk, and so routinely screening is often enough. In contrast, papillomas carry some increased risk, especially when they are multiple or peripheral. In the past, many of these lesions were sent directly to the surgery. Today, with better sampling and complete lesion excision removal, management has become more selective and based on radiological and pathological concordance. Vacuum-assisted biopsy has clearly changed the way. As the saying of Köroğlu, With the invention of the rifle, the old-fashioned bravery lost its meaning. So, after vacuum biopsy, our algorithm has been changed. But this is not a battle between radiology, surgery, or pathologists. One side, vacuum-assisted excision offers us a minimal invasive approach with low complication and good diagnosis. The other side, surgical excision, offers a definitely removal and greater certainty against missed malignancy. Our shared goal is very simple: to treat the patient with the lowest error and the lowest complication rate. Vacuum-assisted excision appears to be a safe approach for selected B3 lesion. But the important part of this issue is this question: which patients truly need a surgery? The first lesion is radial scar. Radial scar is one of the most deceptive B3 lesion because it's histologically benign, radiologically suspicious, and clinically controversial. In simple terms, complex sclerosing lesion is larger than 1 centimeter. Radial sclerosing lesion is an umbrella term. It's included both radial scar and the complex sclerosing lesion. On mammography, especially with tomosynthesis, we usually see architectural distortion with a radiolucent center and radial specules, sometimes speculated mass. On ultrasound, it may appear as architecture distortion too, with mass, isoechoic or hypoechoic mass, and posterior acoustic shadowing. On MRI, it may appear as a speculated mass or architectural distortion too. But if there is no enhancement and the negative predictive value is very high, is nearly 99%. This creates a real diagnostic dilemma. Because of this lesion can closely mimic invasive carcinoma on imaging. For upgrade risk, the first and the most important question is atypia is present. In pure radial scar without atypia is very low, upgrade is 1 to 10%. And if you use vacuum-assisted biopsy, this risk can decrease to 1%. However, when the radial scar is associated with ADH or lobular neoplasm, the upgrade risk reaching 36%. The lesion size also matters. Larger than 2 centimeters, it carries a higher upgrade risk. And the Kaiser score is more than 7 is highly risk for upgrade risk. What is Kaiser score? Kaiser score is a clinical decision tool we use on MRI. It looks few key on MRI is like speculation, lesion margin, and edema, and a Kaiser score above 7, it's a high probability of malignancy. The Kaiser score looks complex at first because it's not a simple scoring table, but it's basically a decision tree, and we can use on MRI. I prepared 3 algorithms for each lesion. This is the radial scar algorithm. When we detect a suspicion finding, we start with a biopsy. The most important question is after biopsy is there is a atypia present or no. If atypia is present, the upgrade is clearly higher, and the surgical excision is usually recommended. But there is no atypia. This is a pure radial scar, and the risk is much lower. In these cases, the next question is whether sampling was adequate. If the lesion was sampled only with core biopsy, this may not be enough sometimes. So vacuum-assisted excision or larger volume sampling is preferred. But if the lesion was well sampled, completely removed, and the radiological pathological are concordant, the imaging follow-up enough for us. Okay, what should be the management if the radial scar with atypia has been completely removed by vacuum-assisted biopsy and no residual lesion? What will we do? This is a hard question. This is a gray zone group. We discussed the case in a multidisciplinary team. But surgical excision is generally recommended in most cases. The main reason is to rule out an associated focus on DCIS or invasive carcinoma. Okay, this is the second lesion. Papillary lesion is one of the most common one, and most of them are benign and intraductal papillomas. They have a fibrovascular core covered by two epithelial layers. This is not a one lesion, this is a spectrum. In the beginning, this is a benign, a pure papilloma, and at the end of the spectrum, you see the papillary DCIS. So the key message is very simple. Not all papillomas are the same, and management must depend on where the lesion lies on this spectrum. An important pathological point is that size threshold is different inside a papilloma. While the usual cutoff between ADH and DCIS is 2 millimeters. But within a papilloma, the threshold is 3 millimeters. And this becomes a key diagnostic distinction for the pathology. On ultrasound, well-defined nodule, vascular stalk or small mass within dilated duct. On mammography, retroalar mass or polymorphic clustered calcification. And on MRI, papilloma often appear a well-defined enhancing mass. The upgrade risk is not the same for every papilloma. Atypia is the strongest warning sign. Bloody discharge, a palpable mass, larger lesion size, multiplicity, peripheral location, and a high Kaiser score all push us towards a more careful approach. Atypia is the key point. A pure papilloma has low risk, but when atypia, especially ADH, is present, the risk increases clearly much more higher. The multiple peripheral papillomas are more likely associated with ADH or DCIS compared to solitary central intraductal papillomas. Papilloma risk is mainly driven by atypia. Poor lesion can carry about a twofold risk, multiple papillomas about threefold. But atypical atypia and multiple papillomas may increase sevenfold future cancer risk. This is algorithm for papilloma. The algorithm shows a practical way to manage intraductal papillomas. We start with a biopsy too. We start with a biopsy, either core needle biopsy or vacuum-assisted biopsy, depending on the lesion. If the patient has bloody nipple,
Dr. Feraman, time is
I have 15 minutes.
bitiyor.
Okay. After biopsy, the key question is whether atypia is present or not. The papilloma contains atypia, the upgrade risk high. If it is pure without atypia, it's much lower, and if it's completely removed by vacuum biopsy, it can be followed by imaging. This is the last one. Flat epithelial atypia is a part of the columnar cell lesion spectrum. It's usually detected on mammography as grouped amorphous calcification. Ultrasound is less helpful, but MRI, flat epithelial atypia lesion, the literature is becoming more clearly. A negative contrast enhanced MRI is also very helpful and very high negativity predictive value for excluding invasive cancer is up to 98%. The sizes matter. It's larger than 2 centimeters. The risks up to 20%, and surgical excision is more appreciated. The flat epithelial atopy usually has a low grade if it is pure, and after vacuum biopsy, risk drop to 0 if 90% of the suspicious microcalcifications are removed. The main risk factors are the concomitant ADH, large lesion size, poor sampling, residual imaging finding, and the older age. This is the summary of the all flat lesion, but if there is associated with ADH or another higher risk lesion, the upgrade is clearly high and vacuum-assisted excision is usually required. Okay, in B3 lesion, the key issue is not only immediate risk upgrade, but also the patients must know long-term risk of developing breast cancer. Endocrine risk reduction is not indicated for every B3 lesion, but in selected high-risk women, it can reduce the future risk of ER-positive breast cancer by nearly 50%. But the real challenge is not the lack of evidence. The gap between evidence and the practice, mainly driven by side effect, communication problem, and the absence of a clear prevention pathway after B3 lesions. Chemo prevention is not a single drug concept. The choice depends mainly on menopausal status. Tamoxifen has the strongest classical evidence, but raloxifene and aromatase inhibitors are important alternatives for post-menopausal women. Lifestyle counseling is not a substitute for proper risk assessment, but every patient with B3 lesion must be told smoking cessation, weight control, regular physical activity, and reducing alcohol intake should be part of the prevention strategies. Shared decision making is essential. This is the last slide. Patients should understand both the short-term upgrade risk and the long-term breast cancer risk, but also the possible harms of the over-treatment, anxiety, and treatment-related side effects. It is necessary to remain under close clinical and radiological monitor. Therefore, the final decision should combine evidence, individual risk profile, and the patient's values and preferences. Thank you very much.
Thank you very much. The management of this kind of lesions is really important. We decided to take questions and comments at the end of the session, if any. The next speaker is Dr. Ahmet Erkek, is going to talk about pseudoangiomatous stromal hyperplasia. Dr. Erkek.
Thank you very much. It was a great honor to be here. First of all, today we are going to speak about the pseudoangiomatous stromal hyperplasia. It was a rare lesion in the breast, but the treatment and the other way is so important of all of us. And we start with this one. PESH is an overgrowth of myofibroblastic cells in the breast. It has an appearance similar to fibroadenoma changes. Pseudoangiomatous hyperplasia, first of all, that was the benign lesion. And some of the cases have breast cancer also because of the pseudoangiomatous hyperplasia, but lots of them have a uncertain currently significance and they are benign. Other cases have made screening for breast cancer difficult, and in some cases impossible due to the number and density of the existing PESH tumors. Here, the etiologic driver, we altogether see the mean age nearly 37 to 40, primarily premenopausal women, and in the hormonal axis, driven by an X-rated stromal myofibroblast response to hormones. Exogenous triggers strongly associated with iatrogenic hormonal augmentation. The clinical spectrum, we first of all, the most common one, focal and incidental one, in the microscopic discovered incidentally in biopsies performed for independent indications. The second one, nodular or tumoral lesions, the patient or the doctor will have. And the common clinical presentation is this one, palpable, painless tumors. This was a painless, it's important I think for you, mobile and firm masses. The diffuse one is very, very rare, but rapid extreme breast enlargement resulting in the gigantomastia. The pseudoangiomatous hyperplasia, the diagnosis is the biopsy. The important differential diagnosis is angiosarcoma, from which it was first differentiated in 1986. First of all, let's look at the differences between them. The PASH and low-grade angiosarcoma, first of all, the differences is the origin. The origin in the PASH is myofibroblastic cells, but the low-grade angiosarcoma comes from the vascular area. The intraluminal erythrocytes, in the PASH we see no erythrocyte, but in low-grade angiosarcoma, erythrocytes are present. CD31 is so important. In PASH, it's negative, but in low-grade angiosarcoma, we see CD31 positive. In the picture, we will see in PASH, the CD42, the stromal cell marker is positive also. And the last difference between them is the atypia and mitosis. In PASH, no atypia and no mitosis, but in low-grade angiosarcoma, we see prominent mitosis. In the microscope, it's much more than 10, maybe. The differential diagnosis, low-grade angiosarcoma, we see it's the CD31 positive, and factor VIII will be there because of it's coming from the vessel. And myofibroblastoma, you see, it has the gene retinoblastoma, 13q14, it's come from there. And the other spindle cell tumors are rare, and they are coming from the fibromatosis. And the radiologic evaluation of this one is the ultrasonography and mammography. And as the patient's age is smaller than 40, we always use the ultrasonography. But if it's higher than the 40, we use always the mammography. There are key differentiation in here. Typical lacks of calcifications will be seen in mammography. They may contain internal cystic spaces. It will be seen in the ultrasonography. And that was a picture about the PASH, pseudoangiomatous stromal hyperplasia. You see the picture. It's the mammography picture. It was a benign lesion. It's seen a benign lesion. And the ultrasound, like a cyst, like a solid tumor in mammography, have a little spaces like the cyst. And the pathology is so important. In MRI, it has a benign kinetic profile, and it's the MRI picture. Sometimes, but rare, it will be a much more big tumor, and you are going to make the surgery maybe. And we talk about the CD31, CD34, and the other ones. It was found in 1995, you see, the ER positive, the PR, the progesterone receptor, estrogen receptors are positive, and vimentin also positive from the structural area, and CD34 is so important for this tumor. It is also positive in the bone marrow cells, in the stem cells, and because of this one, they thought that it's coming from the stem cells. The tumor is coming from the stem cells. And the CD31, we talked about this one, they are positive in the angiosarcomas and the other ones. I think this picture is so important for you because of the pseudo, what does pseudo mean in pseudoangiomatosis stromal hyperplasia? You see, we called it about pseudo because there is no erythrocyte in the vessels. Because of that, they are calling the tumor pseudo is so important, this one. In the lining spindle cells, we see the spindle cells here. In the network slide-like anastomotic spaces and the matrix dense collagen and stroma. I think the most important for this lesion is in the pathology, CD34 is positive for this tumor, and CD31 is negative. And factor VIII also negative because it's not coming from the vessel. And this is the pathologic view. Last two slides, we talked about the spindle cells. In this pathology, we see the spindle cells outside the tumor. And pseudoangiomatous hyperplasia have cystic areas, but no vessels is so important in the pathology. The management of PASH is controversial. Excision may be indicated in enlarging masses or lesions with atypic features. We always don't make any surgery if the tumor is not so much big and the other excisions criteria. Here, I think 2025, the American Society of Breast Surgeons, they talk about the indications of PASH. And the PASH is characterized by myofibroblast proliferation mimicking a vascular lesion. It can be found incidentally on biopsy or may present as a mass or enlargement of the breast. When PASH is identified on biopsy, the pathology considered concordant with imaging, surgical excision is not necessary. I think this is so important. Surgical excision is not necessary for this tumor. But if the tumor goes on, the tumor are bigger, or it has enlargement and any other problems about the tumor, for example, bleeding, for example, necrosis and the other ones, you should have to make the surgery. And biopsy-proven PASH, after this one, observation and surgical excision, we have two-way. The criteria, small asymptomatic incidental findings confirmed by core needle biopsy, action, routine clinical and radiologic follow-up. We always follow up these lesions, but if they are large, if rapidly growing or clinically symptomatic masses, for example, painless or the other one, we are going to make surgical removal with clear margins. And after the surgery, the prognosis and recurrence, my last slide, use the 100 in 100% is benign, but if it carries a little bit surgical weight, if you couldn't take the tumor outside, 15 or 20%, it will make another tumor, it will come, they will come again, and you are going to make any other big incision for this one. But all of the tumors are benign. We are not going to afraid because of these tumors. Thank you very much.
Thank you. Now, the third speaker is from Azerbaijan Medical University, Dr. Kemali Aliyeva, and she will speak about hamartomas.
Good morning, everyone. First of all, I would like to thank all of organization course and especially Professor Dr. Zafer Hoca and my mentor Bahadur Hoca for this opportunity to be here. Today I will talk about breast hamartomas, their clinical features and imaging findings, when and how we should treat them surgically. Breast hamartomas are rare benign tumors composed of disorganized native breast tissues such as ducts, lobules, and stromas. Commonly affect on middle-aged women on their 40 or 45 age, composed of normal breast tissues arranged in a disorganized manner. Increasing number of report cases in recent years, probably better imaging techniques. Diagnosis requires correlation of clinical, radiological, and histological findings. Important to consider the differential diagnosis of other breast lumps. Hamartomas historically first described by Prine, then previously reported under various names, lipofibroadenoma, fibroadenolipoma, and others. Then term mammary hamartoma introduced by Arikin and included in World Health Organization tumor classification. What is a breast hamartoma? Breast hamartomas is benign tumor-like lesions. They compose of mixture major adipose tissue, fibrous stroma, normal glandular breast elements. Represents a disorganized overgrowth of native breast components, typically surrounded by a thin pseudocapsules. Due to mixed breast elements, soft tissue and glandular and fat tissues, typically breast within a breast sign is common radiologic hallmark. According several cases and the last literature reviews, the incidence being among benign tumors range approximately from 0.7 up to 4 and 8%. Most commonly affects women in their 40s age. Rare case reports have been documented on male, also children. Frequently underdiagnosed due to low awareness, core needle biopsy, ultrasound, mammogram, sometimes MRI, and biopsy for confirmation have been provided. Exact pathology remains still unclear. Considered as a result of development dysgenesis, not a true neoplasm. Possible role of hormonal influence given peak incidence in premenopausal women. Rare association with stone hamartomas tumor syndrome in Croden syndrome. Histopathological features, macroscopically, the key features, their hamartomas are well circumscribed, soft form, smooth nodular mass, surrounded by a false pseudocapsula. Microscopic features, disorganized mixture of fibrotic stroma, normal breast lobes and ducts, sometimes small muscles and cartilage can be. Most commonly painless breast lump. Patients present most commonly painless lump, slow chronic mass, soft and mobile on palpation, usually no skin tear, but when the lesion becomes larger and on giant hamartomas, we can see breast asymmetry and cosmetic deformity. This is, for example, a 36 years woman with giant hamartoma, and she had previously contralateral breast cancer. She treated by breast conserving surgeries and endocrine therapy and radiotherapy. On ultrasound, we have some characteristic features. First of them, the fibroadenomas, well circumscribed oval mass, parallel orientation relative to the skin, and their key features, heterogeneous ecostructure due to mixed fat and fibroglandular components, thin echogenic capsule surrounded by lesions, smooth, well-defined margins, no posterior acoustic shadowing, minimal or no internal vascularity on Doppler. We can see on imaging, ultrasound imaging, well-defined and clear margins and pseudocapsules here. Mammogram also has some character sign. The case of features, mammogram features, is breast of breast sign due to mixed tissues and smooth node without speculation. This is also mammogram views. MRI can be provided if mammogram and ultrasound not typically shows hamartoma signs. This is and differential diagnosis of breast hamartomas. It's very important. We can see differential summary in this table. Hamartoma can be differentiated from other breast lesions by their presence of mixed adipose and fibroglandular tissue and the characteristic breast within a breast appearance. Fibroadenoma sometimes can mimic hamartoma, but fibroadenoma, hamartomas inside a lesion, we can see, usually, especially on ultrasound, we can see mixture stromas and fat tissues. Fat necrosis also can mimic hamartomas on ultrasound and on mammogram views, but always has history, trauma, or surgery. We can see this image fibroadenoma, hamartoma, and lipoma, and also we can see breast within breast signs on mammogram views. Also, sometimes phylloid fibroadenomas can coexist hamartomas, but also phylloid fibroadenomas have a hypoiconic solid lesion, but not hamartomas. Breast hamartomas in male are extremely rare. Only a small case have been reported. And clinic features, imaging findings, same as what we can see in female. Also, we can see male breast hamartomas image. Also, in children, is extremely rare. Only 7 cases have been reported. One of them, 13 years boy, he has giant hamartoma, approximately 10 and 10 centimeter, and here we can see scan areas. Malignancy risk very low, overall breast hamartomas and has a low risk of malignancy. Rare case of carcinoma report within hamartoma, invasive ductal carcinoma, DCIS, but reported in the incidence of carcinoma within hamartoma is extremely low, less than 1%. Surgical excision is simple as other breast lesions. Surgical excision is recommended, but not every case requires surgical, immediately surgery. Surgical excision is recommended in the presence of progressive increase in size, symptomatic pains of discomfort, and in giant hamartomas and large hamartomas when they present asymmetry and apoptosis. Breast hamartomas, according to the management, we can say breast hamartomas seen of median age 13 years, premenopausal women, most commonly painless and mobile palpable mass, but only 21% detected during follow-up. Imaging combination with ultrasound, mammogram, and MRI, and biopsy can be performed. Preparative assessment before surgery, clinical examination is very important. Lesion size, mobility, breast contours, ultrasound first line, mammograph and MRI, as I mentioned before, and core needle biopsy can performed if diagnosis is uncertain. Primary surgical objective, complete excision of lesion, preservation of surrounding of normal parenchyma, optimization of cosmetic outcome. Surgical management should be based on lesion size and breast tumors. Excisional lumpectomy is standard surgical techniques. Also, incision depends on localization and size of size of hamartoma, and we can prefer periareolar and inframammar fold incision. Reduction mammoplasty techniques also can be provided if large and giant hamartomas, and giant hamartoma, as I mentioned before, is means of distortion of breast contour ptosis. That's why contralateral breast asymmetry also can be provided. Post-operative pathologic evaluation, pathologic assessment should confirm complete excision of the lesion, typical hamartomas architecture, absence of epithelial atypia, exclusion of in situ or invasive carcinoma. Margin status is generally not critical, but should documented if malignancy is detected. Overall prognosis is excellent. Recurrence is extremely rare. Complete surgical excision is curative in the most majority of cases. No evidence of aggressive biologic behavior. Breast hamartomas not considered as pre-malignant transformation, but transformation is possible due to the presence of minimal glandular breast tissue. Follow-up also straightforward after complete excision. Recommended approach, routine breast surveillance according to standard screening guidelines. No additional oncologic follow-up required on purely benign hamartomas. Enhanced follow-up incidence only if pathology reveals epithelial atypia, in situ carcinoma, invasive malignancy. In my practice, I usually not operate all hamartomas. If clinical findings are clear, and if I prefer to do biopsy, if biopsy also confirm hamartoma, I prefer follow-up and clinical and radiological follow-up. Thank you for attention.
Okay, now we'll introduce the last speaker, Professor Dinas from University of Thessaloniki, for a very frequent condition, fibroadenoma and philotumor.
Respected Chair, dear friends, it will be one presentation actually. There are two, I was allocated to two, which is the fibroadenoma and phyllodes tumor. But in the end, you will see that there's something much more in common than we actually think they had. So I think it will be one presentation in two parts. So it goes like this. Yes, I have no conflict of interest. I'm just a gynecologist, nothing more. Not a very successful one, but I try to do my best. So now we'll talk about, first of all, to fibroadenoma. Fibroadenoma is a very, very usual finding, especially in young women. We find it very often. It is benign, and usually it does not pose any problems. Usually there's much more a hype concerning the fibroadenoma that it is worth. But there is always a problem about communication between doctors and patients. It's not usually what something is, it's something what should or something what could. So if you are discussing with the buyers if something should or if something could, you may operate everybody you see in life, because everything in life should or everything in life could in the end of the day. But the fibroadenoma is actually a very benign situation. It goes like this. Is it going forward with this? No? Super. So there are some special subtypes of fibroadenoma. Usually we do not care what subtypes they are. They are because you can see it in books, you can see it in papers. It is a juvenile. Yes, we can see it in young patients, we can see it in young girls. Usually they come like this. They hide it from the mothers. They come, the mothers comes usually, oh, what is this in my child? Usually it's nothing, it's just a big fibroadenoma in the adolescents. You have giant, you have big fibroadenomas, but usually something which is very big, usually it is not malignant and it's not that many, not so much important. Here is the problem, sometimes you have complex fibroadenomas. A complex fibroadenoma may pose some risk for breast cancer, so you have to be very carefully regarding the management of this. If it is a complex fibroadenoma, it's the only time I encourage to remove it regardless of size, because there are some papers. One, Stefanos, my friend, told me about it. In Israel, it was published, they had a large series, and we usually remove it if it's like this. Cellular, it is much more cellular, but it is not a phyllodes tumor, so we actually do not care about this. And if it's a mixture, it's just a degeneration of a fibroadenoma, which is not a problem. So usually the symptoms, you are all familiar of it, because usually all of you had one or more, usually many cases with fibroadenomas in the past. Usually you have a lump. Usually the girl comes of her own, the young woman. She feels, sometimes it's tender when it has to do with PMT or in the end of the cycle, and it resolves spontaneously with the beginning of the cycle. And usually it is palpable when it is superficial. If it is deep or if you have a big breast, you are not able to palpate it if it is less than 2 or 3 centimeters. So the clinical examination always helps, as helps the history. Usually we have the 3 tools in which we have to evaluate all breast lesions, regardless what is, if it is a hamartoma, which we discussed previously, if it is a pus or whatever it is, you do mammography, you do ultrasound, and if you don't find a conclusion, you do an MRI. For fibroadenoma, usually, because it's also in younger women, less than 30 or less than 40, where the mammography doesn't have any proper sensitivity. It is useless. If you have a dense breast, you do an ultrasound. And usually in ultrasound, you find a conclusion, and usually you are absolutely sure that it's a fibroadenoma in 8 or 9 out of 10 cases. You can do a mammography. Usually you don't need it. If the woman is more than 40, you should do it, because it's a legal requirement, at least in Greece or in other countries I know of. I don't know how things are in your country, but we do it if the woman is more than 40. And if you cannot have any conclusion, then you do an MRI. So if you have all these pictures, you know that it's a fibroadenoma, and in most of the cases, you don't need to do a biopsy. If you see the first time, it's a lesion, a BIRATS 3 lesion. BIRATS 3 lesion means that it's a lesion which cannot be forever a BIRATS 3, as usually the case is in Greece. A BIRATS 3 lesion is a preliminary result, which means that you have to follow this woman up every 6 months for 2 years. After 2 years, this lesion has to become a 2, or if you have a problem, you do it a 4A and you do a biopsy. You cannot have a lesion which is a BIRATS 3 for 3, 4, 5 years or for a lifetime, as we see it in real life. So if you do this, and if you know that it's a fibroadenoma, you evaluate it with these 3 modalities, with this ultrasound, mammography, and MRI if needed, and you come to a conclusion. If you have a real problem or you are not sure about it, do a biopsy. Do more a biopsy, do one biopsy more than one biopsy less. You can do an FNA for a benign lesion. It is a very, very good result. If you have a BIRATS 3 lesion, you think you have a fibroadenoma, the woman is not pregnant, you can do an FNA, fine needle aspiration. It has an excellent prognostic value, and also if you have cancer. But if you have a BIRATS 4A or B, we never do an FNA. But here you can do one, but of course the gold standard is also the core needle biopsy, in which you get results, and if it is something worse than this, you can have also subtypes, receptors, etc. So now you know you have a fibroadenoma. What you have to do? You don't have to do anything. You never ever have to remove a fibroadenoma, except it is a complex one. When do you remove it? You remove it when it is increasing in size. Which size? Actually, nobody knows. There are people who talk 2 centimeters. I think it's nonsense. 3 centimeters starts to make sense. 4 centimeters in superficial ones, and in young ladies, which you see the deformity just, visually, I think it is a must. But I think you have to think about 3 centimeters and above, and if it is increasing in size. If it is increasing in size and quickly, then you have to think about the phylloid tumor, which we'll talk in the end. But usually you don't have to do anything. If you have to remove it, of course you can do it with open surgery. If it is proven with biopsy, you can do it with cryoablation. It's an emergent technique. You can do it with radiofrequency, which we start doing in my department now. You can do HIFU. HIFU is very expensive, needs theater, needs a lot of money and infrastructure. We will never adopt it because it is only there where, let's say, excellence in academic is driven by industry, and we don't have an established industry in this. And of course, there have been some methods trying to solve it by medical treatment. So, surveillance, the most important of all, you just watch it and you don't do anything. Just have it in mind for 2 years to observe it, and then according to the age of the woman, her preference and the guidelines, you do what you have to do. Here it is, should, could, and all of this. Usually, as we talk, you don't have to do anything, especially if you have a core needle biopsy with which you are absolutely sure that this is a benign lesion. It is not like a papillary lesion. So it's like a papilloma, in which papilloma, the role of the core needle biopsy is quite gray, because you may miss the places, because it's like a grape. It is like a grape. It's the papilloma. There may be an area where you have malignant transformations. The rest is fine. But fibroadenoma, it's always the same. Wherever you put the needle, it is the same. So you have the result. So you can be absolutely sure. And of course, there are some cosmetic issues you always have to remember. What do? You do oral lumpectomy if you are absolutely sure of. Sometimes, if you're not sure, you may take some bigger margins. This is a surgery Georgia made here. She's sitting there next to me. Is it working, Georgia? You told me how to do it. I don't know how to do it. There has to be here something you told me. Oh, yes, you see? So this is Georgia operating. Yes, I'm drinking coffee as always. This is very good in life. When you become older, you can drink coffee so the younger staff can operate, and you can watch, do academic work, which means look what's new in the internet, or this. So it is going forward. How can we do it going forward? there has to be, no, this is not a touch screen. Is it going like this? No. Okay. We are going back. No? Okay. She did it fine. The cosmetic result was excellent, as she always is, so she's much better than me. So you can be absolutely that in the aftermath, you could not even see the scar. Vacuum-assisted biopsy, something we do it, the radiologists do it. It is fine, it is safe. You don't have any problem. Sometimes you may have a recurrence because there is still a place, something you live inside and it grows, but this is also not a problem. You can do it again. And cryoablation. Cryoablation is an emerging technique. It helps, it is good. It has very good results in benign lesions. You don't have any problem. You have to assess the patient, and it helps. It is something in which we will hear more and more in the future, because we as surgeons, we do not have to do much with industry, but here it is industry, and the industry is not finding the one who are giving the medication, they're finding us, so they will contact you more and more by the time, so this will become much more frequent in the future. And radiofrequency ablation, this is another technique. I think this works better, and we know that it works better from the preliminary results we have from the cancer patients. We know that from cancer patients, the one who had cryoablation and the one who had radiofrequency, the one who had radiofrequency has a much lower recurrence rate. It's 0.6 compared to 4.5%. So if it works better in cancer, it certainly works better in non-cancer. So this is what we adopted in our clinic, and we start to work with it for the last months. It makes sense. It is not that expensive, and it is good value because not many young girls want to have operations. And HIFU is also a technique. I do not have any experience with this. It is very expensive. Only the machine costs about 800,000 euros. We do not have the money to invest in, so we will not use it. But in centers who have it, why not? There has been some thoughts about pharmacological treatment. They thought about if you minimize the estrogen with giving anti-estrogen medication like aromatase inhibitors or tamoxifen or all the rest, or even GnRH analogs, you may help. There was help. The help was temporary, and there were a lot of side effects. So they abandoned it because you cannot give tamoxifen to minimize fibroadenoma. It is really difficult. My friend Sadaf Alipur in Tehran, she tried and said very good results with metformin. It is a good work. It didn't proceed. After her, nobody else worked on it, but probably in the future, maybe. Stefan always has ideas like this to give strange medication to strange situations. I always say no because I don't have time, but he always thinks about new things, and some of them we maybe adopt this also. So we continue. So this was the first half. I hope I was in time. We go now to the second half, which you will see in the end, it's more related than we thought in the past. Because in the past, we believe that these two are two total different entities. Fibroadenoma is something which is totally benign, but a phyllodes tumor could be benign, could be transformed from benign into malignant, and we know this because we know how they evolve if they have a recurrence, and there is, of course, the malignant phyllodes tumor. This is another entity which has stromal and epithelial elements, and we know that we have a hypercellularity in the stroma, and this leaf like the onion, so it's like leaf. So actually the tumor, it's like an onion. You take the leaves, and in the end, you have the core of it. It is a wide spectrum of atypia. Sometimes could also not be present. So you have all these three categorizations of this. And you see here the three subtypes. It's all these three characteristics they have. And according to them, which is the tumor border, the cellularity, the atypia, the mitotic activity they have, the overgrowth, heterologous elements, and for some people, not for all, also the fact if there is a necrosis, you can categorize them if it is a benign, a borderline, and a malignant one. So these are the usual cases. Almost 3/4, 75% are benign, and the rest is borderline or malignant. And this is also the rate of recurrences regarding the post-operative period. Usually the woman comes, it is a young woman, little bit older than the one with fibroadenoma. She comes with a mass, you examine her, you see the results, you do the biopsy as we did before. Always, always regarding a breast lesion or a finding you have. You always have to use these three modalities. In younger women, first the ultrasound, then mammography. In older women, first mammography, then ultrasound, and MRI when it is indicated, or when the radiologist, which is the first who usually sees them, cannot use a conclusion. In Greece, we have a very big problem because ultrasound and mammography are not paid well by the state system of reimbursement. Radiologists ask most of the time also for an MRI because an MRI is quite expensive, so they get a lot of money. So we have a total overuse of MRI of the breast. But this is the system how it works. Usually we as clinicians, when they come first to us and they don't find it on screening or they don't go to have a mammography or an ultrasound first, we usually do not need an MRI for this patient. We see it, we do the biopsy, so we are done. So this is the usual picture of a phylloid. It doesn't have that big differences the books say about fibroadenoma. Yes, it may have, but it is so easy to take a fibroadenoma as a phylloides or a phylloides as a fibroadenoma. Usually, as when you see giant fibroadenoma or the fibroadenoma which is evolving very quick, you can never ever find the difference. So the difference is found only by the pathologist on the histological specimen you take by the core biopsy. So you see real pictures for patients we have in our clinic where you have mammography, ultrasound, and the MRI. So you do the biopsy. In this case, core needle biopsy is superior than FNA. When we have a suspicion of phylloides, we do not do an FNA. We do an FNA only for patient anxiety in girls, which we are almost absolutely sure that it's a fibroadenoma. So you just do it, not even local we use for FNA, nothing. You do it in the outpatient. She goes and in 2 days we have the result that there are benign cells in there, so there is no problem. But if you have the smallest suspicion of a phylloides tumor, you always do a core needle biopsy. So when you have the result, is what you do then. Of course, the first of all in phylloides tumor is surgical excision, and then there are the other treatments you may do or not. So surgical is the gold standard you have to do. What do you have to do? Of course, you have to excise it. There was a lot of discussion in the past about your margins, and we always knew that we have to have at least 1 centimeter margins from all the aspects of the ball of the tumor, which is quite a lot, because if you think that this is a big tumor, usually more than 4 or 5 centimeters, and you take also 1 centimeter and you put this into the space, not in 2 dimensions, in 3 dimensions, it is a lot of tissue you actually sacrifice just to remove a tumor like this. So there has to be a lot of discussion what to do, and a lot of discussion because then you do a remodeling, and maybe sometimes you have to reallocate breast tissue. If you have to put clips in the edges or not, it is a good practice. Usually we do not practice it in our department. Of course, we know that even if it is a malignant tumor, it doesn't spread through the lymphatic system. It gives hematologic, it gives from the arteries, from the bloodstream metastasis to the liver or the brain, so you don't need to evaluate, and it never ever actually gives metastasis to the axilla, so you don't have to do any axillary evaluation. There are many recommendations about this, but now we know, I don't want you to read all this, there's no question also about this for the exams. The question I gave, they are very easy, so sit the exams, you will, with our questions you will pass, they are very easy. So you just do the examination. Because you do not know how the breast comes in the end of the day, you always have to think that you need to remove more than you initially thought. So you have to discuss with the woman that first you need to remove more, and maybe then you have to make a symmetrization of the other breast. So you have to be prepared before. So actually, as you all know, most of your breast surgeons, the operation is done many hours or days before you do it, because when you know what you have to do and you have drawn your lines, you know what you do, then the other one is just, the part you don't want to do, so there are other people who do it better than us. So you do this, you have the result, and when the result is fine, then you know that you don't have to do anything, and this was the result. Afterwards, it is the same one as previously, so the result is good, and then you just wait the news from your pathologist. So this is actually the algorithm. You have benign, borderline, and malignant. If you have involved margins, so there is what we say, on ink you have a problem, you have to re-excise. If not, you are finished. If it is borderline and you have involved margins, you have to re-excise. And if it is clear, you have to discuss in the multidisciplinary team if you offer radiotherapy, usually maybe radiotherapy, or something more. But if it is malignant, there it is where you actually, it's good to have good clear margins for at least 3 millimeters, which is actually what we use in our institutions. If it is more than 3, it is okay, but if it is less than 3, then you have to reoperate. Regarding radiotherapy, it may help, it may not. It is usually the concept of the stromal sarcomas of other tumors. It does not go 100%, it's not parallel malignant phylloides tumor with a stromal sarcoma, but you can use this concept in this treatment, so it's actually what the radiotherapist would like to ask and how he sees this patient, so we discuss and take the decision accordingly. Chemotherapy, there is actually no recommendation, except if you have other problems, like you have distance metastasis, in which case actually there is actually no need to operate because you cannot cure this poor woman anyway. About adjuvant hormonal therapy or anti-hormonal therapy, there is also no need for this. And you see metastatic disease. Sometimes you see metastatic disease there where you do not expect to have it, but it can occur. There are also people who are born with less luck than some others, and this woman belonged to this. It is usually brain or lung, and in this case the story changes a lot, and it is a not curable disease. So this is actually the follow-up. If it is benign, actually there is no special follow-up. You see her, you do an ultrasound every now and then, let's say between 6 months and 1 year, and after 2 to 3 years you are fine. If it is borderline, if your margins are involved, you have to be more careful. You have to see the woman every 6 months. If it is a borderline, she needs a more tight, a more close, a more good follow-up. You have to see with annual mammogram and every 6 months an ultrasound to see. An MRI you don't need to do, because in the end of the day, you will have sooner or later the outcome in the ultrasound or in the mammogram. And here it is, when you have a recurrence, usually, but not always, phylloides tumor recurs as it was previously. Usually, most of 50 to 60% like this, but there are cases, of course, if it is malignant, you cannot have a recurrence as a borderline or a benign. There is no deal about it. But if it's a benign or border, even a benign can recur as a malignant. Not very, very often, but it can. So you have to be absolutely sure about the margins that you have removed it. We are usually we sleep better if we have clear margins all the time. For local recurrence, you don't need to do anything big. You just have to reoperate, especially if it is a borderline or if it is a benign. You just save the area, you take it out, and you are finished, and there is no special treatment after that. All these guidelines, you know them, you can take them for free from NCCN. And here is where the story changes, because medical oncologists, because they have to do a lot of the genetics, they try to find why some, if they're all good, well-operated ladies, why some of them recur and some of not, if it doesn't have to do with a surgical skill, and if it doesn't have to do with metastasis in the other part of the body. So they went into the genetics, so they find some mutations which are in these women, which are responsible for the recurrence. So they find some genes, and one of the most important genes, the MED12, a transcription regulator, and then they find some other genes. And when they find some genes and they make some conclusion why some of the operated recur and some of not, then they found that this role of genetics does not only apply to phyllodystomy, but also to fibroadenoma, because a big majority of women, as you see, the MED12 is found in the most of the women with fibroadenoma, and a lot of with phyllodystomy. So actually, in the last years, the thinking went down from surgery or from imaging, but it went to genetics, to find which are these players which have a problem in the future. They are working on it. And we know, because this is this difficulty, we have sometimes diagnostic difficulty, we do not know what it is. We cannot stratify the woman, find the patients according to the risk, and we need to know the biology for the recurrence. So we know now that there are these key players, these genes, which could produce a problem, and it's not that we know why you have a problem. It is very important that because of this, you may be able in the future to find some therapies according to the type of gene mutation you have. So actually this is the new thinking, that you have the normal stroma. For some reasons it's MED12, it becomes a fibroadenoma. Usually it sleeps, but some of them, for some other epigenetic reasons and some other mutations, become phyllodes tumor, a benign one, a borderline, a malignant, and in the end of the day, if you are unlucky one, as we said, then you have a metastatic disease. So now, as we saw some previous presentations, AI is helping a lot. We have in our department an AI expert. He's a professor of informatics, so he helps us a lot. I don't understand exactly what he is doing. He always wants picture and histology result for us. This is the only thing I gave him, and he makes big proposals and big projects with the European Union and Commission, and it seems to be working fine. So I think AI is helping a lot of us. I am in a generation in which I will not see that big evolution, but the younger ones of you surely will see it in the future. And this, because this also is not yet implemented in the practice, we usually start to thinking still in fibroadenoma and in phyllodes tumor according to imaging and according to surgery and pathology. There are some minor differences between the scientific academy and committees regarding how to stage, how to follow up this patient. Usually there are no big difference. So the national guidelines, what we do in Greece, because we are a very small country, we are half than Istanbul, so we usually take the guidelines from other countries and try to adopt it to the Greek reality. But the guidelines are guidelines, and medicine is unique wherever you are. So actually, for the end of the day, the two last slides is the differences which we saw between fibroadenoma and phyllodes tumor. Fibroadenoma is in younger women. It grows slow, it's small in size. Usually it's mobile and smooth and not that firm, homogeneous. You do a biopsy, you have a histology, and the treatment, it could be in fibroadenoma, but it has to be if it is a phyllodes tumors. So usually for fibroadenoma, it's very good just to have a surveillance and only to intervene if there is something in which causes concern. But for phyllodes tumor, you have to be very careful. It's good to have a good margin, and if you don't have the margins you would like to have, you have to have negative margins. You have to observe closely, and if it is something which is malignant, then the MDT plays a very big role. And I think I'm done with this. Thank you so much.
Yeah. Okay, now it's time for question and answers from the floor.
Tamer.
My question is how to identify complex fibroadenoma.
It's only, first of all, you don't see the homogeneous appearance usually in ultrasound. It doesn't have feature of degeneration, but it is not the real potato you see. You know, it is, even if you have a fibroadenoma or you have a fibroid, because we are gynecologists, it has the potato appearance. It is everywhere the same. It doesn't have degeneration. It doesn't have calcification, especially if you see it. If you have a fibroadenoma, which you have carried for 20 or 30 years, you may have calcification, but not in a young patient. He will put it 4A. Yes, or 4B, I know this. But the radiologist always want to have peace in mind, and he always put it one step more, and then write clinical reevaluation. So we know this, yes. But we will, a complex, it is a 4A complex, because it doesn't have the appearances of the real potato appearance. Yes.
Okay, I have one remark for Kostas. Thank you very much. In my opinion, I think that I agree with you regarding a young patient that you could perform FNA, but in general for older women and for a tumor bigger than 2-3 centimeters, I recommend core biopsy. And we had 2 cases with FNA negative, and these continue to grow, and after the core biopsy it was actually a DCIS. And we should not forget that about 2%, and in some series a little more, there is in complex fibroadenoma a DCIS in the periphery of the fibroadenoma. So it is very important.
He told a very important word. In older women, all this, what I talked, are in younger women. A woman after 50 or after menopause is not allowed to have any change in the mammogram or in the ultrasound. It may appear as benign as you may think. The nicest thing which you see for the first time in menopause or after menopause is cancer, unless you have proven otherwise. So this all is for reproductive age. If you have a nice smooth tumor with parallel to the skin orientation, with nice margins, no halo, no vascularization, everything is fine, but it is in a lady 55-year-old who has her yearly mammograms and her yearly ultrasound, and you see it for the first time, the first diagnosis is cancer. So you do a biopsy. You are only allowed to have this if you are in the reproductive age, not if you are in the menopause. In the menopause, the story is total difference. It is like the one, the previous presentation about B3 lesions. If you have a B3 lesion, in biopsy, you have to operate. If you have a B3 lesion, in the end of the day, you don't have to do anything. So it is totally different if you are reproductive age or if you are in the menopause.
We should never forget that there is 2 type of cancer, the medullary carcinoma and the tubular carcinoma, which have exactly the same aspect in mammography and in ultrasound. And if you don't have a proven by the histology, we can't miss it. I think so.
It is.
Now, I have one question for the first speaker, for Dr. Sinafer Rahman. Is he here? Yeah. Yes. Thank you very much for your nice presentation. I think that you should add in the float chart of the management of papilloma, when you have all the possibilities, to follow up and to discuss if it's not a papilloma complex or not, the dactoscopy with duct lavage and brushing. It is a very new aspect and very new approach to differentiate a simple papilloma to a complex with fibroscopy, dactoscopy, duct lavage. And in Turkey you have Professor Alsik. She's making this technique. Yeah.
Thank you very much for the presentations, and I would like to ask to Dr. Ferahman. In the third consensus meeting, the recommendations based on open excision or vacuum-assisted biopsy, except for epithelial acid, generally, the vacuum-assisted biopsy or excision is promoted, and when we carefully dissect the consensus recommendations, almost half of skill consists on vacuum-assisted excision. What is vacuum-assisted excision? Indications, exact, and the limitations, especially in terms of diameter, ATP, or microcalcification. Maybe this is not your question, a radiology question, but as you give the lecture, please.
Thank you for question. I have the same question too, because it's a little bit gray zone. After vacuum-assisted excision or biopsy, except you say flat epithelial ATP, except the other beta lesion, we use generally open excision. We make open excision, but it depends on where you live in. If you are living in US, open excision is more useful, but in Europe, the industries push up vacuum-assisted excision. In Turkey, we reach vacuum-assisted excision a little bit hard where you work. It depends on where you work, but after, if the lesion has atypia, after vacuum-assisted excision, I do open excision if the lesion has atypia or a bigger size.
Any other questions from the audience, if any? We have 10 minutes. You have?
I agree with, how is his name? I agree with you totally, and I want to point out more that when you have a papilloma, intraductal papilloma, you could perform a surgery, ductal surgery, by the ductoscopy. That's the technique of Funerbine. We use it in my department in Greece, and it is a minimal surgery by ductoscopy after the duct lavage. Yeah?
Mr. Dinas, I recommend for your slides, in one of your slides, for the biopsy, if the lesion is lower than 3 centimeters, the biopsy is required. However, in our clinical practice, for example, for my pathologist, even after a solid lesion bigger than 1 centimeter, my pathologist say we prefer getting a biopsy, corneal biopsy, and my pathologist gives me 3 results: fibroadenoma, fibroepithelial tumor, or benign, maybe benign. If he says a fibroepithelial tumor, even the tumor is diameter is lower than 3 centimeters, even 1 centimeter, we prefer re-excision. We prefer excision of the lesion, because fibroepithelial lesion is maybe a fibroadenoma or phylloides tumor. The pathologist cannot differ by making pathology. So I think not 3 centimeters is something high. We prefer in our clinical practice, if a solid lesion over than 1 centimeter, maybe it's okay to follow up, but nowadays we prefer getting biopsy, and he says if it is fibroepithelial lesion, we prefer removing it. Another comment, also we have some cases.
How many percent do you have?
We have some cases.
How many fibroadenomas do you send for biopsy? Because if you send too many, there is something, a problem in the clinical practice, if you send too many fibroadenomas. But if you send something which may be suspicious, how many of them, in the end of the day, he has to reevaluate the result he had from his biopsy? And the final result of the surgical specimen the same he had before or not?
Generally, we have rare cases. We have rare cases. But why we do this? We don't have enough time for cancer, even for cancer patients. So, by doing this equipment, I prefer getting biopsy. If it is benign, I don't remove any fibroadenoma. I just make follow-up.
Just to make it clear for the younger ones, there are international guidelines And the international guidelines say with a triple assessment, which is imaging, the most important, you have to have a bias number. And according to this, you have to deal your case. If you have a bias 3, you can follow it up, or you can do a biopsy in 3 cases. When she lives in a remote area and she cannot be put for follow-up, if she is pregnant, which is a total problematic period in life, or if she has anxiety. These are the only 3 reasons somebody with a BIRATS 3 lesion should have a biopsy. Otherwise, you follow the BIRATS 3 biopsy with 6 months intervention for 2 years, and then you have a BIRATS 2 or a BIRATS 4. If you have straight ahead a BIRATS 4A, you should do a biopsy. So actually, before going to what we say and what the pathologist says, it is to know what we have in paper written from the radiological imaging of the woman. This is the most important thing. Because if you have a problem with a biopsy concerning the radiological image, then you have to evaluate the radiological imaging. Because there are guidelines and there is a special pathologist which has a personal opinion. For me, it's totally different. You have to adhere to the guidelines, and the guidelines they are strict. If you have a lesion which is BIRATS 3, you know what you have to do. If it is 1 centimeter, or if it's 5 centimeters, it is a BIRATS 3 lesion. And BIRATS 3 lesion, if there are fibroadenomas, if it is a hamartoma, if it is whatever, it is a BIRATS 3 lesion. So BIRATS 3 lesion have a flowchart. So these were BIRATS 3 lesion, and if there are BIRATS 3 lesion, you need to do what is written in the Do you say the same thing or not?
In the past, our radiologists say this is a fibroadenoma on sonography reports. Now they say a solid lesion, approximately 2 centimeters. A solid lesion. What is your fibroadenoma or fluid tumor?
Usually radiologists, I hate radiologists, I'm sorry, I don't know if somebody is here. I hate them, and a gynecologist, MRI of the pelvis is a disaster, she knows a disaster. If you have, from me, radiologist, I want only two words, sorry. Only 2 words. What is the ACR of the breast, ABCD, how dense is the breast, and what BIRATS it is. I don't want descriptions. I don't want it looks like this, and suddenly we are after the moonlight, and beside this, a little bit behind, and left to the region. I don't want this. I want these 2 numbers. ACR in mammography, and BIRATS in mammography and ultrasound. I am the clinician, I will decide. If a radiologist cannot do that, he needs to study further.
We have many branch 0 reports nowadays.
This is a problem we have in Greece. This is also why I hate radiologists. Because they do not know to come to a conclusion, and they say BIRATS 0, inconclusive to ultrasound, do MRI, and after they've done all the 3, clinical assessment, not clinical follow-up. It is the same. It is the same. There are many types of doctors. Radiologists are specific. Maybe I'm also specific. I don't know, but I don't get well with it. I have a problem. This is the reason, knows, that why we established in our department, we do it all of our own. We are not allowed by law to do mammography, but all ultrasound biopsies, all of them. They always expanded. Some months ago, Georgia was there, you were there. We do it because we know how to do it, and we know. And at the end of the day, all the one in Greece, very stellar, all of Cyprus, everybody, in the end of the day, they need also informal assessment, because if you have, I don't know how many percent BIRATS 0, you are not able, you should not be able to do mammography or ultrasound. BIRATS 0 should be very, very minimal. Very, very minimal. Do you have another question?
No. So, yeah. Yes, the only thing I have one comment is I think very important for two concerns. The first is that with the biopsy we never have the margins. And that's the point. When for borderline lesion we don't know the margins as are clean or not. And the other point, I don't know if there is some pathologist here, but you know maybe that the difference between atypical hyperplasia, which is a benign lesion, and DCIS, which is early breast cancer, it's only a question of millimeter. The same lesion, 2 millimeter, is hyperplasia, 2.1 millimeter is DCIS. So it depends very much of the pathologist. And there is about 20 to 30% discordance between the diagnosis of the pathologist. So we have to be very careful with the borderline lesion.
Okay, thank you very much. So we don't have a break now. We'll go straight to this young investigator sessions. We have 4 distinguished scientists who will be presenting their presentations. And I would like to invite the chairs of this session again, Professor Konstantinos Dinas and Professor Zafer Utkan, to run this session and moderate this session. And after each presentation, we will be just, hearing the questions from you. So we will not wait until the end of the session to hear your questions. So you can be free to ask your questions, but we want a brief, questions and brief answers to each one of them. Okay, floor is yours, Kostas and Professor Utkan.
Hello. There is no coffee break. It will be after that. On behalf of my co-chair, you are welcome in this session. So this is something very, very important for me personally. I always have a very. This is actually the scope of all my academic career. It is the young investigations, the young doctors. This is what we are here for. Otherwise, we will do something else. So I read the program, and there are some very, very interesting presentation. And the first of one, it is Denise Healy. It is the number 1 outcome of best B3 lesions. So all these equivocal ones, a single center retrospective study. Dr. Healy.
Good morning, everyone. Thank you for this invitation. I'm Denise. I'm a surgical trainee from Malta. And today I will be presenting our study about the outcome of breast B3 lesions in a single center, and it was a retrospective study. First of all, Malta is an island in the Mediterranean, and we have the population of just over 500,000. And we have one national hospital. So all the major investigations and procedures are all performed within one hospital. And that means that our data, our study is a realistic reflection of the entire population of our nation. We have one breast unit composed of 5 specialist surgeons, breast surgeons, 3 oncologists, excellent breast care nurses. We have also a breast physician, pathologist, and radiologists. And all these specialists form part of our MDT, the multidisciplinary team. We also have a national screening program where all females between the ages of 50 and 70 years are invited every 2 years to perform a mammogram. That means that our detection rates of breast diseases are very early, and hence the long-term outcome of breast disease has been excellent, some of the best in Europe. We have up to 500 new cases of breast cancers per year, so it has been a very busy unit. So, what is the B classification? The B classification is a pathological classification of breast tissue, usually biopsies taken either as part of the triple assessment or else in view of changes noted on imaging, either on the screening imaging or else as opportunistic imaging. It is a classification that was founded in the UK. It has been used for over 50 years, and it is basically a classification between B1 and B5. So B1 represents normal cellular architecture of breast tissue, while B5 is usually the presence of malignant breast cells. B3 falls somewhere in between. They are described as lesions of uncertain malignant potential, and thus they impose a challenge to design the best management forward for each patient. These are some examples of B3 lesions, as previous speakers have described before me. So we have papillomas, lobular neoplasias, atypical intraductal epithelial proliferations, and all of these cases are discussed in our MDT, a meeting which happens once a week. So what was the aim of our study? The aim of our study was to evaluate our numbers and how are we managing these B3 lesions, and also to analyze the rate of histological upstaging of these lesions. The method. So it was a one-year retrospective study. We collected data over the year of 2025 between January and December. All candidates were female candidates above the age of 18 years, and they all had to have a B3 diagnostic pathology on the initial biopsy. We had a total of 83 patients, so 83 diagnoses of B3 lesions, with a median age of 52. The biopsies were either core biopsies, the majority were core biopsies, up to 80%, and some of them were vacuum-assisted biopsies, 20% of them performed by our specialist radiologists. And then we looked at the initial results. Up to 35% of them were papillomas, so by far papilloma lesions are the commonest B3 findings. And we also noted to have flat epithelial atypia and radial scars, which were also some of the commonest results. So as we said, each case was discussed at the MDT, and the management plan was designed. Some patients were offered follow-up, so that is active surveillance, usually including yearly mammograms and ultrasounds, while other patients were offered excision. So this could be either vacuum-assisted excision performed by our radiologists. We had up to 23%, and 45% of our patients underwent surgical excision under general anesthesia by our breast specialist surgeons. The result of each was, of course, noted. So out of our total of 83 patients, 57 of them underwent excision, either surgical or vacuum-assisted, and 10 of these had resulted into upstage histology. That means that 17.5% of the B3 lesions that were excised showed histology, either evidence of the CIS and pre-malignant disease, or indeed the presence of cancerous cells. As we said, so 10 patients had the presence of upstaging, 8 of them being low to intermediate the CIS, and 2 of them having invasive cancer. So this is a table where we tried to find the correlation between the initial B3 histology and the final upstaging histology. Papilloma was noted to have the highest rate of upstaging, but also ADH and AIEPs had a significant rate of possibility of upstaging. In this forest plot, we can see that we analyzed risk factors of who are the patients that have the higher risk, where their B3 lesion has a risk of becoming something more serious. Age was the most significant risk factor, so obviously the older the patient, the higher the risk factor of developing upstage disease. Also, as shown in the previous slide, the presence of IEPs and ADH was also a significant risk factor when calculated on our forest plots. So, in conclusion, the upstaging rate of our study of the B3 lesions was up to 17.5%, which is very similar to what is found in international studies and literature. Why is this study important? It will help us to make future decisions in our MDTs to be more informed and more of an informed decision. And also, perhaps it will give us ideas to perform other studies. First of all, perhaps we can perform prospective studies to closely document and evaluate what is happening to our B3 lesions, and also to see what is happening to those cases that are subjected to surveillance. So if the initial B3 lesion is not excised, what is happening, let's say, in the next 5-10 years? Is there any change in their imaging? Do they need rebiopsy? Or perhaps the outcome of the MDT changes and they will be later on subjected to some sort of excision. So thank you for attending this presentation. We are very proud to be collaborating with our Turkish colleagues. Our history runs much deeper than you would assume. Also, I would like to invite you all. This was our conference last October, but I would like to invite you all for our breast cancer conference in October of next year, where you can obviously have further discussions with us and also enjoy our beautiful country. Thank you.
Thank you, Dr. Hill. Second author, Merve Kukaş'ın, please. The subject is endoscopic versus open gynecomastia surgery, multi-center retrospective comparison and aesthetic outcome, patient satisfaction and nipple areolar complex sensation. Please, Merve.
Hello. Hi, I'm Merve Tokaçın. Good morning, everyone. Thank you for being here. Today I will present our multi-center retrospective study comparing endoscopy and open gynecomastia surgery. In this study, we focused on aesthetic outcomes, patient satisfaction, and nipple areolar complex sensation, and pain and complications. In this study, we have 55 patients from 2 tertiary centers. Let's begin. As we know, gynecomastia is the most common benign disease for men. It affects both physical appearance and psychosocial well-being. Many patients experience embarrassment, social anxiety, and low self-confidence. Medical treatment can be helped, but after fibrosis tissue, the surgery is the most common options for treatment. But open surgery is still as a standard approach, but the standard approach, and endoscopic is and the endoscopic one is the other option. Because of limited comparative data in this literature, we want to compare the 2 approaches in details. We designed that study as retrospectively as 2 centers, and patients just include Simon grade 2 and 3. The endoscopic group includes 25 patients and 49 beds, and the technique is we use the small incision, rigid endoscope, and Tmeson infiltration. And the second group is open to 1, and 30 patients is in there, and 58 beds include that group. In this technique, we use periareolar or infraareolar incision, direct excision, and standard electrocochlear dissection. Our primary outcomes are pain, knock sensation, aesthetic score, best Q satisfaction scala, complications, and is there any necessary for revision surgery. And that's the incision that we made in endoscopic surgery, as you can see on the mid-axillary line. First, the two groups are were statistically similar. There is no significant difference in age or Simon grade or body mass index or smoking or alcohol. But when we look at the operative findings, endoscopic procedure took a little bit longer time as the open one. But incision size is much more smaller, blood loss was lower, hospital stays was shorter, and the specimen weights were similar between groups. That means it's the minimal invasive approach did not reduce surgical competence. And when we when we look at this figure, the pain is lower in endoscopic group. At the 12 months, endoscopic groups were completely pain-free, and we believe this benefits related to soft tissue trauma, lower incision size, and less flap elevation. And most important finding is aesthetic superiority of the endoscopic approach in this study, we guess. As a surgeon rated scores, the significantly better in endoscopic one. And the scar quality was also better in the endoscopic group, because this is expected one because the scar is hidden. So patients reported satisfaction with breast Q chest module. It has 12 points between groups. This is important because exists the minimal clinical important difference is important. It's really meaningful in this statistical results. There's only not a statistical significance. It's also meaningful patients in daily life. As a most important, this slide shows knock sensation, and both groups had decreased at 6 months. This probably related to postoperative edema or neuropraxia, but at 12 months, endoscopic groups recovered much better than the open group. Clinically significant hypoesthesia was only in 16% in endoscopic group and 62% in the open group. This is maybe because of the axillary approach is better preserves lateral intercostal nerve branch. We guess that. And there is no numerically significant statistical difference between the groups, but There is more seroma and more ECMOs in the open group. There is no reoperation or no recurrence in the both groups. The important findings was sensory and patient satisfaction and less pain, better scar looks, and the only disadvantage was a longer operative time in the endoscopic group. The difference was around 6 minutes. Of course, we have limitations. This is retrospective and just a few patients we have. In conclude, there is less pain in open, there is less pain in endoscopic group, smaller scar, lower blood loss, better nipple sensation, and better scar quality and higher patient satisfaction. And if it's possible, this technique may become an option for selected patients. And because even a pearl acidic choice can reshape destiny, just like the golden apple of Paris. Thank you.
Thank you so much. Are there any questions from the audience?
No.
No questions? Can I make a comment? A small one? No. You see that 10% are not satisfied whatever you do it. If you do it open, if you do it laparoscopic, endoscopic, they're not satisfied. So these 10% are everywhere in life, you know. Thank you so much. So we proceed with the next presentation. Yes, I need my glasses. Yes, exactly. It's paper number 3, pure atypical ductal hyperplasia on breast biopsy. Yes, upgrade rates, risk factors, long-term outcomes. Adnan Gündonglu.
Good morning, everyone. Thank you for the opportunity to present our study. Today, I will present our findings on pure atypical ductal hyperplasia diagnosed on breast biopsy. We analyzed the upgrade rates, risk factors, and the long-term outcomes in cohorts of 251 patients. This is a collaborative work with Dr. Gentile and Professor Corrado Tunteri from Humanitarian University, Italy. When we encounter pure ADH on core biopsy, the key clinical questions: should we excise or can we safely observe? Our study had 3 main objectives. First, to determine how often pure ADH upgrades to malignancy after surgical excision. Second, to identify which factor predict that upgrade. And the third, to evaluate the long-term oncological outcome of these patients. This was a descriptive retrospective cohort study including 251 patients with a pure ADH on breast biopsy. All patients underwent a surgical excision. About 70% of biopsy were vacuum assisted, and 30% were core needle biopsy. We used logistic regression and both univariable and multivariable analysis. And also, importantly, our median follow-up was 9 years, and this gives long-term data. Looking at the demographics, and the median age was 48 years. Nearly 2/3 of the patients were premenopausal. Family history of the breast cancer was present in about 9%, and only 2% had a personal history of breast cancer. Regarding genetic mutations, the vast majority, almost 97%, had no known mutation. Only 2 patients carry BRCA mutation, and 6 had other non-BRCA mutations. Moving to imaging and the biopsy findings, most lesions were non-palpable. At 64%, detected primarily through the mammography and ultrasound. Calcification were seen on 1/3 of the mammogram. Artificial distortion in 12%. On the biopsy vacuum assisted, on the biopsy site, vacuum assisted biopsy was the dominant method at the nearly 70%. The solid pattern was by far the most common historical pattern at 76%. The vast majority of the lesions were unifocal. Sorry. Now, here are our surgical findings. And this is the central result of our study. The overall upgrade was 4.8%. This was evenly split. 6 cases of invasive carcinoma, all non-specific type and luminal-like. And also 6 cases of ductal carcinoma in situ. Sentinel lymph node biopsy was performed in 10% of cases. On univariable analysis, 4 variables reached statistical significance: age, 50 and older, postmenopausal status, genetic mutation, previous breast cancer history. On multivariable analysis, genetic mutation emerged as the only independent predictor of the upgrade, and also postmenopausal status showed a trend, but didn't reach significance. So, to summarize our study, the upgrade rate from A to H is low at 4.8%. Genetic mutation is the only independent risk factor we identified for upgrade. And age over 50 and more, postmenopausal status and the previous breast cancer were also significant on univariable analysis. Our long-term data with our 9 years of follow-up shows a very low recurrence rate, only 0.8%. So, for the patient with pure ADH and no genetic mutations, close surveillance may be a safe and reasonable alternative to routine excision. Thank you.
Thank you. Last. Oh. Okay. Please.
Yep.
12 years ago, the situation was upgrading from about 25%. So it's important what happened in these 12 years. Much more vacuum-assisted biopsy. So we are more aware that it's only ADH on the biopsy, and for that reason you have some. For me, it's amazingly very low percentage of upgrading. But I bear this in mind. You did a lot of vacuum-assisted comparative with the 4 biopsies we used usually.
In your practice, right?
Probably this is humanitas. This is why they have this low rate. If it was a general hospital, they would upgrade it a lot, but they have a good diagnosis beforehand. This is why they upgrade in a lesser situation.
Right.
One, two.
Is there any question?
They are having also at higher risk women with typical included hyperplasia, typically hyperplasia. They include also a prevention treatment with tamoxifen or exemestane. So did you check also in your study with these well-validated questionnaires and risk assessment tools before waiting 12 years, because you follow up 12 years, so if you would have applied at the basis this calculated risk, maybe these women may get, in Europe we are not giving tamoxifen, but maybe you will get some other surveillance. Thank you.
Yeah. We don't use any calculator, that's only a retrospective study because of, yes, because we don't have any chance to use any tool, actually. No. Yes, maybe, right.
Yes, please.
Thank you very much. In our experience, we are on the way to publish. It's about 8 to 10%. Anyway, I agree with everything that you show us, and congratulations. My concern is that 5% in statistics is not low, it's high. And because when you also do everything for hormonal receptor, when it's 5%, it's positive. When you make a study and you have P005, it's significant. And 5% to 10% depend, it's 1 of 10 of 1 of 20 patients. It's not nothing. I'm concerned very much about 5%. If it was 1 or 2%, okay, but 5% to 10%, it's not zero.
Right.
You did very well.
Thank you, Adam. Last young.
May I ask a first presentation?
The lady from Malta, yes?
As far as I understand, therapeutic vacuum does not guarantee negative surgical margin if the lesion upgrades to malignant. In the first presentation, the therapeutic vacuum rate almost 33%. Did you see any malign upgrade in after therapeutic vacuum biopsy?
The question again, please.
So, I mean, the patient B3 lesions, 32.5% underwent vacuum-assisted biopsy. Is there any patient among the vacuum-assisted biopsies? Have you ever seen malignant conditions? Because negative margins, it's impossible after vacuum.
Yes, we did have some results of upstaging.
What did you do after
We
when you see the...
We provided a wide local excision, and on the histology there was evidence of invasive malignancy accompanied by sentinel lymph node biopsies. So an oncological resection, essentially.
Yes. The last young investigator is Georgia Marjorie Fjord. Topic. Clinical epidemiologic characteristic of breast fibrilloma and differences between surgical and conservative management. A single center core study. Please, Georgia.
Esteemed chairs of the session, dear professors and colleagues, good morning.
So on behalf of my department, the second department of obstetrics and gynecology from Thessaloniki, alongside, of course, my professor and mentor, Konstantinos Zinas, I'm going to present a cohort study, a retrospective one, that we did regarding the clinical, epidemiological, and histopathological characteristics of all women treated for breast fibroadenomas in our clinic. So, as it has been underlined in the previous presentations, of course, breast fibroadenoma is the most common benign disease that we find in the breast, especially young women, and the management may vary. There is a great spectrum, as Professor Dinas told us already. So we can either go from totally conservative management with surveillance to, of course, surgical excision, and there are many factors that we should weigh in during this decision that we should make about our patient. However, histopathological confirmation of the fibroadenoma is not always an easy case. There are some tricky cases, especially when we have histological overlap with phyllodes tumor, and this may pose challenges to the management. And of course, having a better understanding, a deeper understanding of some clinical epidemiological variables regarding the profile of the fibroadenomas, this may help us choose the correct therapeutic pathway, of course. So, the aim of our study was to evaluate the main clinical, hormonal, epidemiological, and histopathological characteristics of the women that we treated with fibroadenomas in our clinic, and then we attempted to do a comparison for the majority of those variables between patients that we treated with surveillance and patients that we treated surgically. So, it was a 2-year retrospective cohort study. It was conducted in our department, as I already told before, and we included all teenage and adult women that had histologically confirmed fibroadenoma. We have already done a core biopsy to confirm it, and the majority of women, they underwent the CNB due to enrollment in an academic educational protocol that we have in our clinic regarding CNB. And of course, we included patients that were either treated with conservative management or patients that they received surgery, surgical excision of the lesion. We collected our data regarding the main epidemiological, clinical, and histopathological, as well as variables regarding hormonal exposure for these women. And then we attempted, as I already told, a comparison for the main variables that we collected and analyzed. And then we proceeded to take a greater look in our surgically managed cases, and we analyzed the indication of the surgery. We saw the lesion size dynamics for the patients that we have a follow-up period about, and of course we did a concordance regarding the pre-operative and the post-operative histopathological report that we got for the women that were operated on. And we performed our statistical analysis with the SPSS software using proper non-parametric and parametric statistical tests. So, proceeding to the results, we had 106 women with histopathologically confirmed fibroadenoma through core biopsy in our department for this time of period that the study was conducted. The main age at diagnosis was 33.5 years, and the median, to be more correct, BMI was slightly over 25. So the majority of women were just a little bit overweight. And about a quarter of them, they had a family history of fibroadenoma regarding their first and second degree relatives. Proceeding on to the hormonal and reproductive profile of the women, the median menarche age was 12 years of age, almost just a little bit upper from the 0.5%. The women, they were nulliparous. And for those that have children, the majority of them had 2 children, and the age of first delivery was at 25 years of age. Just a small fraction of the patients were postmenopausal. The majority of them, as expected, were premenopausal, and just 12 patients, so 11% of our patients, used oral contraceptives. And proceeding to the actual characteristics of the lesion, the median size at diagnosis was 14 millimeters. The majority of patients, almost 8% of our patients, had just one lesion, one fibroadenoma. And 22% of our patients, they complained of persistent symptoms that they were not well tolerated with conservative management. And the main symptom that women were concerned about was, of course, mastalgia. Of those 106 patients,
38 of them, so almost 36% of our cohort underwent surgical excision of the lesion that was identified as fibroadenoma. And proceeding on to the direct comparisons regarding the majority of the variables that we have already discussed between patients receiving conservative and surgical treatment, as you can see, and I'm going to summarize that, we did not have statistically significant differences regarding the majority of the epidemiological and the hormonal factors that could weigh in and that could potentially play a role in the formation of fibroadenomas, namely the BMI, the family history, the age of menarche, the parity, and the age of first delivery, as well as the menopausal status. However, we find differences in 3 of the variables that we examined. So, as expected, the women that were treated surgically had a bigger size of lesion at the time of diagnosis, and this was statistically significant, but this is mostly anticipated, since the size is one of the factors that we take into consideration in order to decide for surgical excision. But however, we had a slightly unexpected result. So the women that they underwent surgical excision, they were more frequent users of oral contraceptives. And we're going to discuss that a little bit later. However, the population, as I already told, that was using oral contraceptives was very small, only 12 patients out of our cohort. And finally, as also anticipated, women that underwent surgical treatment, they had persistent symptoms that were affecting the quality of life. This was more frequent, of course, in the patients that received surgery, and this was statistically significant, as you can see. So regarding our cohort, the main features and variables that they were associated with eventual surgical management was the size of the lesion at the time of diagnosis, the presence of persistent symptoms, and the use of oral contraceptives. And let's dive into a little bit more at the patients that received surgical management. Why did they receive that management? So for the majority of cases, the indications were those 3. They, as you can see, combined that surpassed the 50% of the cohort. So the size at diagnosis, the presence of persistent symptoms, and the rapid increase in size during follow-up were the main reasons that we operated on these women. And regarding the size, because it's something quite ambiguous, as Professor Dinas already told us, not all guidelines are aligned on that. When we performed surgery at these women, the majority, the median, just to be correct, size at surgery was 20 millimeters, but this includes all the patients for all the indications that we performed surgery on. But if we just minimize, if we just make a little small of the population that received surgical treatment and see the women that were excised due to size or rapid increase, then the median size at surgery was 36 millimeters, so it was significantly higher. And if we want to see what did we consider a rapid increase, because this is also not something well documented in guidelines, regarding only the patients that were operated due to rapid increase, this increase was 20 millimeters in a median follow-up period of 17 months, ranging from 13 to 21 months regarding the follow-up period for those patients. And finally, the final histopathological report that we received were consistent and concordant with the one that we received preoperatively through the core biopsy for the majority of cases. But there were 6 cases that we had discordance between the preoperative pathological report from the core biopsy and the postoperative final histopathological report after surgical excision. And the final diagnosis for these 6 patients that initially received the diagnosis of a simple fibroadenoma was what you see right now on the slide. So we had 3 patients that were eventually diagnosed with complex fibroadenomas and 3 patients that were eventually diagnosed with benign phylloides tumor. And the indications for the surgery at these cases were not, of course, only the surgery after the core biopsy. As you can see, this was only the case for one woman that was finally diagnosed with complex fibroadenoma. We also performed surgery at these cases of disconcordance due to size of diagnosis, due to radio and pathological discordance, and of course, regarding especially phyllodes tumor, as expected, the rapid increase in size. So let's see what the literature says about the statistically significant results that we had in our study. As I pinpointed before, the result regarding the use of oral contraceptives was not expected because it's not aligned with what we know. And we have a lot of data that shows that actually the use of oral contraceptives, especially those containing estrogens, but we have increasing data also about those containing only progestins, so that they have actually a protective effect for the development of the fibroadenomas. So what we had was not expected. However, I find just one study, a big Swedish cohort study with almost 60,000 patients, where just a small fraction of those 60,000 patients, that's 45 patients actually, no, 54 patients, they developed breast cancer after being diagnosed with fibroadenoma, not on the same lesion, a subsequent breast cancer. And for this very small percentage of the patient, the use of oral contraceptives was found to be a risk actually for development of subsequent breast cancer. However, in our cohort, we mainly attribute this result, of course, to the very young age of the women that used oral contraceptives. In their vast majority, they were below 30 years of age. So it's a subpopulation that more usually uses oral contraceptives. And of course, we had a very small subpopulation using oral contraceptives, just 12 patients out of 106. Regarding our other significant results, of course, they are anticipated. We know that for the majority of the cases, however, taking into consideration other factors, a size above 3 centimeters is usually an indication for excision. And of course, when we have a persistent symptomatic fibroadenoma, this is a sole indication that can be accepted when it affects greatly the quality of life of the woman. And finally, our upgrade rate. It's not usual to have a high upgrade rate from fibroadenoma when we have a preoperative histological diagnosis to phyllodes tumor. So I found a cohort of 112 patients that had an upgrade rate of 9%, but the upgrade rate was mainly distributed in patients that have big fibroadenomas, initially diagnosed lesions as fibroadenomas, that they were older, and that they had a high radiological suspicion of having something more than fibroadenoma. But when we receive a preoperative diagnosis of a fibroepithelial tumor, not a fibroadenoma, then the upgrade rate is greater. And according to a study from 2017, in the American Journal of Surgery, it may reach 37.5%. So when we have ambiguous results or when we're not sure regarding the histopathological report, of course, a consultation from an expert, from an experienced pathologist may lead us to a most correct therapeutic approach. So to conclude, of course, we know, and there is a lot of studies, epidemiological studies focusing on that path, that there are various epidemiological features and clinical ones that could be affecting the progression of fibroadenoma. And usually the clinical features is those that lead us to the surgical management. In our cohort, persistent symptoms and increased size of diagnosis were one of the main significant differences between the two groups regarding the approach that we followed, alongside the paradox result of the use of oral contraceptives. Of course, main indications for surgical management is the increased size, the rapid increase size during follow-up period, and the presence of persistent symptoms. And when we have a preoperative pathological report, however, when indicated to do a core biopsy, this leads us to lower upgrade scores. But in any case of ambiguous results, of course, the expert opinion of a pathologist that is experienced in that kind of lesions may provide us a more accurate result. Thank you very much for your attention.
Thank you very much. Perfect. Is there any comment?
Actually, my question is directly to Dr. Dinas. In my practice, I prefer to remove surgically all palpable fibroadenomas because it provides me both diagnostic and therapeutic. And my person, but a certain amount of the patients, for example, more than one fibroadenoma is available, fibroadenomatosis. And if other ones non-palpable, I keep them under observation. I would like to have your comments.
Regarding if a fibroadenoma is palpable or not, it does not have to do with the pathology of the lesion. It has to do with the level of the breast regarding to the skin it is. If it is more superficial, it is palpable. And if you have a size a cup A or B, it's more easily palpable. If it is in the lower third and you have a cup C or D, it's not palpable. And from all the data we have, we know that there is no special area in the breast which is more, let's say, prone to have a malignancy or to have a degeneration or anything of a lesion regarding its location. So for us, location plays only a role if they cause a visual discomfort, if it is very big and very superficial, just under the skin lining, and it causes that discomfort because it is visible or the boyfriend, the husband, the partner does not feel it. It's only a part of location for us, and from the data, as far as I know, location does not play any role in the management of a lesion.
So, thank you and well done for your amazing presentation. Few comments about my practice and our population, because we have different, obviously, cultures and levels of anxieties. I think when we have a virus 3 lesion or a new fibroadenoma, and it's reported as virus 3, our radiologists, rightly so, they report it as virus 3, and we offer both follow-up and biopsy. And most women nearly exclusively choose biopsy because, according to your practice, 2 years of follow-up every 6 months, it is associated with most of our patients with a level of anxiety which they cannot tolerate. Besides being, in my mind, difficult to justify if there is, after 2 years, a diagnosis of a cancer. Because then medically, how can you answer that question? So you missed my cancer for 2 years. We could blame the radiologist, we could blame the team, but at the end of the day, the patient will complain that you left a lesion for 2 years. So our patients like to have a biopsy, and if it is benign fibroadenoma, they don't usually want it excised because they trust the pathologist, they trust us, and they don't, I mean, this issue of premenstrual period, discomfort, and so I think it's partly associated with anxiety. So, your comments about,
I can totally understand that there has to be some local, regional adaptations or changes to the guidelines. But in the end of the day, guidelines are guidelines. There are strict guidelines about a lesion. First of all, let's stick to the guidelines. Before surgery, you need a biopsy. I think there is nobody here in this room who goes straight ahead to surgery, even if he is more than 100% sure that's fibroadenoma. Nobody ever makes a surgery before a biopsy, without a biopsy. We are 100% sure about this? Everybody, yes? So you do a biopsy. If you do a biopsy and you have a benign lesion, in the European Union we have some guidelines regarding the data you must have being a certified breast cancer center. So you cannot, the surgery of non-cancerous lesions should be limited in less than 10%. These are our guidelines. So I cannot operate in the state system in a cancer center, not cancer, because the other one is anxious. It all depends how you inform patients. There is biased information. It's the most easy things to do. If you just don't talk and just say one like this, it's done. The patient is fearful. So you have to stick to the guidelines, and if you stick to the guidelines, you can stand also in front of the court, yes, because this is life. We do not operate, because can you imagine if you have a benign diagnosis on biopsy, and you proceed to an operation, and then she cuts a bug in the hospital, you know, a hospital bug, which could lead, there is a presentation here somewhere, to necrotizing fasciitis or a rest like this. How will you justify it? Then you must be absolutely sure that she will tell the lawyer that I didn't have the right information for the surgery. I thought they didn't explain to me that it was such a minimal possibility to be something. Nobody. Do we know that an earthquake will not do now and everything of this will fall us apart? Is it 1 to 10 the possibility? Is it 1 to 1 million? So actually when you have a benign histology, a really benign histology on biopsy, we are not justified in our state system to do it. If you won't take the lady, do it privately. In the private office, you can do whatever you want, but not in the same system.
No, we are in agreement completely. I'm not, actually, we nearly never, if not never, operate benign fibroepithelial tumors without complexity more than 4. My only issue, and our patient's only issue, is not having a biopsy diagnosis. So relying solely on a BIRES classification. Because BIRES 3 is less than 2%, but 2% is significant as well.
Well, this is the most important
So
development.
with a biopsy, we never operate.
Yes, but this is the development in imaging over the years that we can communicate. If now we take under discussion that a BIRATS 3 is not a BIRATS 3 and it's a BIRATS 4A or it's a BIRATS 2, then the whole system of radiological imaging and classification disappears. A system has to rely in each of its parts. You need to have a radiologist which gives you a precise diagnosis. This is the reason I hate this specialty.
But again, they have a difficult job, Professor. I mean,
No, they don't have a difficult job. I'm sorry about this. No, I'm not a trained radiographer, and I know that my trainees, they are much better than the average radiologist in breast ultrasound, because we don't do mammography. It's just a matter of training.
Most of us will do an ultrasound, but they will not commit themselves over it's a fibroadenoma or not on ultrasound.
Yes, I must tell you that when I started the breast unit 15 years ago, this is my personal, I bought an ultrasound with a linear probe, and I did breast ultrasound and biopsies, and the radiologists were asking, what is he doing up there in the 4th floor? It is a reality. And then she is here, they came to us, and we learned the biologists, the radiologists to do breast ultrasound, to take biopsies, to put clips. They didn't know it. We gynecologists, and we're not even surgeons, we're gynecologists, and we learn them how to do it. So it's just a matter of practice. If somebody sits like the 3 previous one here, who sits in the night and study as residents, and they do it, they can do it. I don't know how it is here, but in Greece we have a very big problem with imaging. It is a disaster. Sorry, yes. We can discuss later. Now there is lunch break.
Okay, no, not lunch.
No, not lunch.
Before that, thank you very much for all the speakers so far. Now, this is not a pre-planned thing. Now, we have a ceremony because we encourage these young investigators to come here and give their talks. So there was a hidden jury members in the audience, and we asked them to rate these 4 presentations. And I asked them to give us their results and decisions so we can present the best paper award to one of those 4 speakers. So I would like to ask the jury members, the speaker, have you received the decision? The microphone? Yeah. This is a surprise. It's not written anywhere.
Yes, thank you. Thank you for choosing us for juries, but we understand why you choose us, because it's very hard.
It was a random thing, you know. It should be a random, you know.
It's a hard job because we have 4 excellent and excellent and.
Can I have it?
Okay. Okay. We have. Okay.
Let me see the results first. Yeah? Yes,
You need also a hostess then.
yeah. As you see, we do something, you know, in a good way. All right. So, let me read it. Need to put my glasses. All right. Oh, surprise. So, thank you very much for the decision here. So, we had 3 jury members, and the best paper goes to all 4. Thank you very much. So I would like to ask, I mean, this is a very difficult decision. So how did you come to this decision, Sina?
We have 4 excellent and valuable presentation. Because of this, we choose 4 winners.
Right.
Thank you
okay.
for, thank you. Thank you for
That
all.
was difficult for you to
Yes,
choose
yes,
one. Okay, here is the decision so you can read it, okay? It's not a blank page. All right, I would like to invite first Professor Can Türk as the convener, and also Kostas, please, Konstantinos Dinas, and also Stefanos Zervoudis as our past president in the society, and Professor Utkan as the chair, and also our past dean for the faculty, to give the, you know, awards. No, I'm the speaker here, you know, so that's why I'm here still. Oh, thank you very much. So I would like to first invite Dennis, the first speaker, the first presenter. Come here.
Thank you so much.
You're welcome.
Thank you very much.
Okay, Dennis, you can stand here, just beside me. I would like to invite the second presenter, Merve Tokoçin. And so, and the third presenter, Adnan Gündoğdu. And Stefanos. So you may give the certificate and the present, the award. Okay, Adnan, come here, please. And the last presenter, Georgia, please. Yeah. And Professor Utkan will give the award. Now we can have a photograph all together, please. Now I'm enjoying it.